So basically, the problem that you have is you have two discs in your neck and your spine that are pushing into the spinal cord. So basically, the spinal cord lives in a tube, and your tube, instead of being a normal area, is compressed from these two discs pushing on the spinal cord. And the spinal cord is what gives you strength and sensation and the ability to walk. So this pressure, if it's on for a long time, can affect your spinal cord function, which is a big problem. If you feel like you get worse, you need to call me right away. But if you feel all right, there's no hurry about it. So the surgery is through the front of the neck, and it's an incision. It usually goes from here to here, you take the disc out through the neck. You can't go through the backside because the spinal cord's in the way. So the structures, there are many things, just so you remember, there are many things that could go wrong, and usually the things are catastrophic when they happen. They're very bad, but they almost never happen. But I have to go over them all, okay?
Okay.
So the things that could be injured in the front of the neck are the esophagus, the tube to your stomach, trachea, the windpipe, artery to your brain, voice box nerve. Everybody has difficulty swallowing for a week or two, but that usually goes away. Hoarse throat and strength of your voice, but usually these things go away in a couple weeks. Once I get down to the level of the disc, I have a huge microscope that goes over you, so everything is magnified like over 10 times during the operation. The point of the magnification is it gives a very clear picture, and also it makes being careful very easy, so everything's magnified. There's a very important reason why you have to be careful is because the surgery is on top of your spinal cord. If your spinal cord gets injured, it's extremely unlikely, but if it gets injured, it always here is a chance that you could be paralyzed from the surgery. It's extremely unlikely. So the things that we do to avoid that are, meticulous surgical technique, real careful, and also monitor the spinal cord with a computer. So you'll have all these little needles in your hands and your head and your legs, and it'll run a current up and down your spinal cord, and there'll be a person watching everything on a computer. If there's a problem, the computer should register it. Nothing's 100%, so even the computer sometimes gives false positives, false negatives, but it's one more added level of safety. So you take out the whole disc to the level of the spinal cord. Once the disc is out, there's a hole left where the disc used to be, so you have to fill that with something. There are many options out there to fill it, and there's all sorts of probably 20 options you could use. I usually use bone. And the reason why I use a piece of bone is it's a standard conservative thing that is known to be very good results. You put a piece of bone there. Now you can use either your own bone or you can use somebody else's bone, and that's called allograft. Somebody else is actually another human being who's, they don't need their bones, so they donate them, and the company shaves them so they fit just right. You put the bone in, and the bones will heal into this allograft bone. In general, it takes about 6 weeks, but the whole incorporation of the bone takes a year or two. What happens is your bone grows into it and lays down its own bone. If the bones do not fuse together, do not weld together, the pain usually comes back in about a year or so. That's called non-union. You are a little bit at risk because cigarette smoking. So after surgery, you have to quit cigarette smoking, then you're not at risk. And then after the bone's placed, I almost always use a plate and screws to hold it still. The plate and screws are flush up against the bone, so you shouldn't feel it at all. And you leave it in for life unless you have a problem, like with your spine above or below. And the other thing is the fusion surgery. You weld the bones together, so the levels higher or lower may go bad in your future. That's called adjacent segment degeneration. So the whole operation takes about maybe an hour and a half, 2 hours. You go home next day. When you wake up, there's a drain in your neck for fluid. If after the surgery you notice you can't breathe, there's always a chance that fluid could be pushing on your windpipe. You're not to ignore that. You go straight to the ER or call me. All these are extremely unlikely. In general, most people feel pretty good at 6 weeks, and 2 weeks, and 6 weeks you should feel fine. So I usually give people a collar, a hard collar. It's just to immobilize you. I think it decreases pain. It's not really that necessary, so you can take it off. but I think it's good to have just for extra protection.
Range of motion changes?
Yeah, there is some limitation to your range of motion when you weld it together, but usually people don't notice a difference. It usually does not, give you less ability.
The joints above and below kind of
Right,
adapt to it.
right. Most of the range of motion of your neck occurs at the very top of your spine, where the skull meets the spine, at the base of your skull. So that's where 50% of your motion is, and the other 50% is down here. So we'll be fusing two segments, so you'll probably have like 20% or maybe 30% loss of motion of the bottom part, so most people don't notice a difference. So any other questions at all?
Your best estimate on how long to wait?
The decision
Don't wait
is yours.
too long to become symptomatic, but...
Well, there's an extremely low chance that if you were involved in a motor vehicle crash, because you have pressure on your spinal cord, that you could be paralyzed from the operation, from the injury, from the accident. Right. It's extremely unlikely. Usually what happens is people get something what's called central cord syndrome, and it usually gets better, but you don't want it if you don't have to. But it's extremely unlikely for you to get into a serious car accident. Reasons why you should definitely have it are you can't use your hands. Your hands feel clumsy. The other thing is when you walk, you feel like you're drunk, but you're not drunk. Those are reasons definitely to have it.
Okay. Or any little thing that I may ignore without this type of diagnosis, I would want to...
Well, if you feel like you have problems in your hands and they're going numb and you can't use your hands, it's a problem.
Okay. I'm going to talk it over with my wife.
Yeah, take as long as you want. Do you have any other questions?
Well, I don't want to take too long either, obviously.
Right.
No, that's total recovery time. You said it's about 6 weeks.
6 weeks total. You can go back to all sports. 6 weeks. Just start real slowly. Anything you want, But in general, if you have an easy job, 2 or 3 weeks, you go back. You can probably even go back sooner than that. It depends on the individual and what your job's like. And
just from my personal experience, you use epinephrine when you go in through the front to... Okay. Had a bad experience.
I don't use it.
Oh, you don't? Okay, good. Had a bad experience when I had my salivary gland taken out.
Okay, I'll write that down.
They used...
I'll write down the analogy.
They were supposed to use 100,000 to 1, and they used 1,000 to 1.